Welcome to our 5th educational seminar on extracorporeal circulation. Thank you all for your participation in these seminars. I believe that sharing experience and knowledge is very beneficial for everybody, so we can reach excellence. Now I would like to give the microphone to my colleague and cardiac surgeon of cardiac thoracic department of General Military Hospital of Athens, Dr. Charalambos Georgiou.
Thank you. Welcome. My name is Georgiou Charalambos. I'm a cardiac surgeon in the Military Hospital of Athens. It's a great honor for me to co-chair this session with Mrs. Athina Aramu, who is a chief perfusionist in our hospital, and Mr. Konstantinos Pereas, who is director of First Cardiac Surgery Department of Onassis Cardiac Surgery. Mr. Pereas is the surgeon who has the largest series of thoracoscopic procedures at Onassis Cardiac Surgery. Thank you for coming to our hospital, Mr. Pereas.
Thank you very much. Congratulations. This is a great initiative, I think, indeed, because it improves knowledge for everyone, and the congratulations to the Army for supporting this. So without much ado, let's start with our first speaker, who's an experienced anesthetist. Dr. Spiridakis Emmanuel is going to talk to us about anesthesia for endoscopic cardiac surgery. He's an anesthetist as a coordinator in the Department of Anesthesiology in the Hospital of Aegea in Athens, Greece. Dr. Spiridakis, the podium is yours.
Thank you very much. My name is Spiridakis Emmanuel, and I am Director Anesthesiologist in Aegea Private Hospital of Athens. And I will present you some key points regarding anesthesia for minimally invasive cardiac surgery. This emblem represents the great role of the anesthesiologist. Is from Juan Marin, a Latin American anesthesia pioneer. And it's based in Greek mythology, where the night has twin sons, Thanatos, death, and Hypnos, sleep, who carry flaming torches pointing towards the floor to light a path through the dark. A small light between Thanatos and Hypnos, this one, represents the key role of the anesthesiologist. The flame represents the flame of life the anesthesiologist must guard. The upper half of the emblem shows the rising or setting sun of consciousness. So minimal invasive cardiac surgery. This is the most common approaches, surgical approaches. In the upper and to the left, we can see the approach for total endoscopic aortic valve surgery. Lower and to the left, we can see the surgical approach for minimally invasive mitral valve surgery. And to the right, we can see the anterolateral thoracotomy for minimal invasive direct cardiac surgery or minimal invasive cardiac surgery, coronary artery bypass grafting. The advantage of these minimal techniques are down here: faster recovery times, minimal tissue injury, reduced blood loss, lower infection risk, enhanced cosmetic outcomes, shorter hospital stays, quicker return to daily activities. Regarding the history of cardiac anesthesia, in 1953 is the introduction of CPP, something which changed the world of cardiac surgery. In 1972, we have the intra-aortic balloon pump, and don't forget here the first publication in 1962 in American Heart okay, I don't remember the exact name, but the first publication was from Dr. Moulopoulos, the Greek Dr. Moulopoulos, and we have to remember always him. In 1979, we have the PA catheter. Also in 1978, we have the high-dose phentermine anesthesia. This is a protocol of anesthesia, but now we don't use it because we had frequent arrests during induction of anesthesia and very late emergence from anesthesia, so we don't use it anymore. Around 1990, we have the color TE and the TE practice guidelines, and after 2000, we have the different blocks for postoperative analgesia. We have the generalized use of transesophageal echocardiography. Mix means team approach, and team approach means good communication between surgeon, anesthetist, scrub nurse, perfusionist. They have to train together and to progress together. They have to follow WHO checklist, debriefing, weekly M&Ms, and case discussions. New era, new anesthetic challenges. Many skills together in one person, the anesthesiologist, regarding lung isolation, patient position, cannulation, TOE, post-op analgesia. Also, decreased surgical exposure means more vigilance for hemodynamic instability, cardiac ischemia, bleeding, tamponade. The anesthesiologist must share concerns early with the surgeon. This is important in every cardiac surgery case, but in mix is essential. Regarding patient selection, we want a patient with BMI under 30, cardiothoracic ratio under 50, good coronary targets, favorable peripheral vasculature, no severe adhesions, without inability to use TE. FEV1 above 60%, PO2 above 70, PCO2 under 50, 55, left ventricular diameter below 50, ejection fraction above 40, no pulmonary hypertension, only mild impairment of RV, TR, MR, AR, only mild, and the ratio of E waves under 15. And if you are in the beginning of our learning curve, we have to remember what said Michael Mack, who is a cardiac surgeon of the United States, who said, don't drive a Ferrari the day you get your driver's license. Start simple, easy cases first. And now I will present you some directions regarding cardiac anesthesia. It's the directions and not the exact way to do things, because the art of anesthesia is different from anesthesiologist to anesthesiologist and from institution to institution. We want to know first the Euroscore 2 to predict the risk of mortality and morbidity. We want to know frailty assessment because it connected with morbidity and mortality also. We have to know the delirium risk factors, age, frailty, pre-existing cognitive issues and/or mood disorders, and excessive alcohol use. Hemoglobin A1C, if above 60 to 70%, is a marker of poorly controlled diabetes and a predictor of postoperative complication, including deep sternal wound infection. Serum albumin below 4 is an indicator of malnutrition and an independent predictor of increased morbidity and mortality. Urine albumin is a risk factor for postoperative acute kidney injury. Obstructive sleep apnea screening. We have to know these patients because they have because the obstructive sleep apnea is associated with postoperative respiratory complications. We have to know also opioid tolerance assessment to know this opioid tolerance, because this contributes to hyperanalgesia and opioid tolerance, and maybe we have to change our pain management plan. Smoking cessation at least 4 weeks before surgery. Pre-admission information, education, and counseling for patient and families. High protein energy supplementation for at least 1 week before surgery. Intensive nutritional supplementation for 5 to 7 days in patients with preoperative serum albumin below 3. Exercise training for 4 weeks before the surgery. 6 minutes walk test to see the frailty assessment. Management of anemia. The best time is 3 to 4 months before the surgery, but even 3 to 4 weeks before surgery is enough to give ion therapy and erythropoietin. This is especially important for Jehovah's Witnesses patients. Continue clear fluids 2 to 4 hours before anesthesia. And here are some key points regarding surgical site infection prevention. Smoking, okay. Chlorhexidine alcohol-based bathing the night before surgery. And topical intranasal staphylococcal decolonization. The best medical practice for that is to see the patient 4 to 5 days before the surgery, to take a specimen from the nasal, and if it is MRSA positive, we can start mupirocin, which is the best studied, for 4 to 5 days before the surgery. If we put only mupirocin the day before surgery or hours before surgery, it's not so good because of bacterial resistance. Intraoperatively, clipping and not shaving, we know that. Chlorhexidine, alcohol-based solution. Appropriate time for antibiotics, 30 to 60 minutes is the best before the incision, but regarding vancomycin, it's 2 hours before the incision. Intraoperatively, pre-mitigation, pregabalin or gabapentin. Minimize anxiolytics, including midazolam. We don't want midazolam, generally speaking. Antifibrinolytics, 1 gram tranexamic acid before CBP and 1 gram after CBP. I think it's a low dose, and in our institution, we give 2 grams before and 2 grams after. Avoid hyperthermia during rewarming. Keep temperature below 38. Avoid hypothermia. Keep temperature above 36 in operation theater. Separate from CPP at nasal temperature above 37. Underbody bear hugger after CPP at high. Room temperature at 22 after CPP. Warm all fluids. Sterile bear hugger for lower limbs. Warm gown and blanket upon exit from OT. Avoid sternal wound and donor site infection, as we mentioned before. CPP management, optimal flow 3.2 liter per minute per square meter, zero fluid balance, minimize vasopressors. And rigid sternal fixation, myo wiring for patients with high BMI, previous chest wall radiation, severe COPD, or steroid use. Preventing nausea and vomiting with ondansetron or the combination of dexamethasone and ondansetron. Standard anesthesia protocol, avoid benzodiazepine and anticholinergic because of the delirium risk, and full reversal of neuromuscular blockage. Lung protective ventilation. NIRS in selected cardiac patients cases. Atrial fibrillation prophylaxis with amiodarone intraoperatively in patients with enlarged left atrium, reduced left ventricular ejection fraction, and past history of AF. Multimodal analgesia, more agents, lower complications. Dexmedetomidine intraoperatively, starting from time of CBP to ICU. Wound infiltration for postoperative analgesia. Surgical access considered minimal invasive. This direction is not only for minimal invasive surgery, but for cardiac anesthesia and cardiac surgeries. Prevention of gastric ulcer, omeprazole the evening before and the day of surgery. About blood conservation in cardiac surgery, we have here the strong regarding the strength of recommendation, and the A regarding the quality of evidence. And this is the use of antifibrinolytic, off-pump cardiac surgery, retrograde autologous priming, acute normovolemic hemodilution, and the use of point-of-care tests. Postoperative analgesia. Here we have the thoracic epidural analgesia, but it's difficult for same-day admission, may lead to cancellation of the day, high risk of complication, especially epidural hematoma and spinal cord injury. There is also the paravertebral block, intrapleural block, intercostal nerve block, and also serratus anterior plane block, pectoralis facial 1 and 2 blocks, erector spinal block. From my experience, in thousands of cases, cardiac cases, I think that thoracic epidural analgesia is the best of all, but it has limitations. The other blocks are good, but not enough to relieve 100% the postoperative pain. I think that, I believe that contributes to 55 to 65% to relieve the postoperative pain. We need more medicine, more painkillers, and we need multimodal analgesia, and we are far away from opioid-free analgesia. Postoperatively, remove the nasogastric tube, early extubation in operating table or within 2 hours of ICU arrival, sedation continuing with dexmedetomidine in ICU, avoidance of hypothermia, maintenance of chest tube patency, no milking or stripping tubes, active tube clearance device, early thromboprophylaxis, early detection of kidney stress, detection delirium screening once a shift in the ICU, glycemic control, fluid therapy near zero fluid balance, multimodal analgesia. LA local anesthetic infusion for the pain, postoperative nausea vomiting prevention, ondansetron, diet support, iced chips when extubated, diet as tolerated after passing swallow test, gum chewing 3 times a day. Bowel motility, laxatives from postoperative day 1, lactulose. Postoperative investigations in first 24 hours. Drains lines removal, patient care, family conference, patient brings own preferred music, shower on postoperative day 1, allow patients own clothing, spectacles, hearing aids on postoperative day 1, allow newspaper, TV, iPad, laptop. And physiotherapy begins at the day of admission in ICU. Physiotherapist, upon patient arrival, assess calf force, airway reflexes, and mobility score. 3 hours after arrival, sit on bed, transfer to chair, resistive exercise on upper and lower limbs, and when seated, intermittent non-invasive ventilation and flow incentive spirometer. And physiotherapy in post-operative day 1 and discharge criteria of pressure agents for up to 3 hours with systemic blood pressure above 90, SpO2 above 94, below 50 ml per hour chest tube drainage for 3 hours, heart rate below 60, above 60, below 110, heart rhythm unchanged for 3 hours, no patients in second or third degree heart block, mental status at patient's baseline state, patients must have tolerated being out of bed without hemodynamic stability, patients must have at least a 20G peripheral IV access. And here is a 6-hour transfer protocol. When we have aortic or mitral minimally invasive valve surgery, the patient, or robotic, and also...
Can we speed up a bit, please?
Okay, and
yes.
also robotic aortic and mitral valve surgery. The patient comes to ICU, and if they fulfill the transfer criteria, after 6 hours, maximum 12 hours, they leave ICU, and after 48 to 72 hours, they leave hospital. This is a patient from our institution after ultra-fast track extubation on table. Thank you very much.
Congratulations. This was really very nice because I think you covered more or less everything there is to know, and there's a lot of space for discussion. So that's why I wanted to give some room to discussion. Maybe Dr. Falara, our anesthetist from Onassis, would like to make a comment. She's our most experienced TOE and minimal invasive anesthetist, even though she's so young. So with a lot of future, I guess.
Okay.
Thank you for the invitation. A very interesting speech for a topic that is becoming more and more hot. I would just like to make a small comment on the role of the anesthesiologist in this setting, because I think that in the setting of minimally invasive cardiac surgery, the role of the anesthesiologist becomes more and more crucial, because this kind of procedures, they are not possible to be carried out without the use of a transesophageal echocardiography that the anesthetists do. It is imperative, sorry, that there is guidance through transesophageal echocardiography for many reasons, for the placement of the cannulas, for the CPB, mainly for the venous return. In addition, what? Huh? No, for the hearing, yes. The small incision doesn't give the surgeon the opportunity to have access to the whole image of the heart. So the echo, we are in some way the eyes of the surgeon in order to monitor systolic function of the heart, to monitor that the cardioplegia is effective, to monitor to assess the procedure result.
Very nice, very nice. Thank you very much. I think really it's a relief for the surgeons too, because it's always the anesthetist's fault, isn't it, when something goes wrong? So here we can add more blame to our anesthetist because we can't see what's happening. You are exactly our eyes. Can I just ask you, I think on what you mentioned about the postoperative care, I mean, maybe in a year you are succeeding, I hope you are, and I'm not judging, but I think I find it very difficult to transpire all the information and all the knowledge that you guys have and we share with you in the so-called ERAS environment. Some of that is what's being proposed to minimize everything, not just the wound itself, to assist the patient in the best possible way. Do you find there is resistance in the communication with our ITU doctors, or are you
ICU doctors
in a line with our ICU doctors? We have RT to speak to them most of the time because I can't do it properly. So,
do you want to speak or I speak? Okay. There is problem always, but we need more communication, more training, more together doing things, and we can prove ourselves and go further.
Thank you very much. Yes, it's something we need to improve on our communication with them.
We are not at the best.
Any questions from the audience? Any comments? Right. Congratulations. Thank you very much.
Thank you.
I think for the sake of time, we'll have to move on.
Yes. Our second speaker is Professor Granov Nermir, who is Director of Surgery in Clinical Centers, University of Sarajevo, Bosnia and Herzegovina. It's a recorded presentation because Professor Granov is traveling to Seattle right now, so he can't be online. So we're going to hear his presentation online.
Good morning. I would like to use this opportunity to address you and to give a talk for endoscopic mitral novel strategies and endoscopic way of the Sarajevo Center. So, minimal invasive cardiac surgery has started in 1996 with the Cosgrove, performed the first minimal invasive surgery in 1998. He described various operative approach in 115 patients. After that, we have the Carpentier also did the operation, and also the Randall Chitwood, he described the procedure of minimal invasive cardiac surgery with 31 patients, and also he described a novel instrument that he used during the operation. Since then, the size of the approach is decreasing, and at the beginning from a full stenotomy, and now we have a situation that now the size of mini thoracotomy is less than 2 centimeters, and it's newly called micro thoracotomy. So where we are now with these procedures, despite all the data that shows that minimal invasive is superior than the osteotomy, not so many centers do it in everyday practice. UK mini trial showed the superiority, but if you can see here, only 12% of the patients are operated that way. The same situation is in Germany, but from year to year, the numbers of the minimal invasive endoscopic cardiac operations are rising. So there are so many kinds of CPB protocols. In our institution, we are going through the right groin, and we are going directly with the Seldinger technique. Now you can see here that we are first placing sutures with a 4 prone suture, first on anterior, then on venous side. With the Seldinger technique, with the TEE eco guidance, we are introducing the first arterial, then venous line. We can see the how we're doing that. And as we introduce the cannula, we are starting immediately the CPB, and then we are placing the lungs like lines down, and then we are starting the opening the chest. But prior to the operation, we are doing the meticulously diagnostics for checking how the vessels are, if they are dilated, or they are curved, or they have atheromas. So if we are happy with the pre-operation diagnostic findings, then we are doing the operation through this remote femoral access. Also, before the operation, what we must do is to check for the all kind of anatomies. We are doing the multimodalities, as we can see here with the MRI scan, transesophageal echo for checking about, also the CT scan, as you can see here, and the X-ray chest. This is how we are starting the operation, and this video will show we can do it through the second intercostal space. And some cardiac surgeons prefer second intercostal space because you're going perpendicular to the pectoral muscle. Then we are going to the intercostal muscles perpendicular. This is how it looks like when we are approaching through the second intercostal space. It is possible to reach every wall in the case that we need to. Also, besides that, we can do it through the third intercostal space, as you can see here. And the places where we are placing the port on the right hand side, you can see how it looks like in real life. Then we can use the next approach through the nipple, like a nipple cut, as you can see here on the right. And it's suitable for all ladies. And the next part will show you how it looks like when we are to the nipple cut. So we can do mitral tricuspid and even aortic valve in some cases. But most preferable one, in my opinion, is the lateral mid-axillary approach with 2 centimeters in size. So as lateral you are, the better visualization is. Here are the retraction sutures that we are placing for exposing the pericardium. Now we are placing the stitches on the ascending aorta. For placing cardioplegia line. This is the device for securing this, and after we deliver cardioplegia, we will cross-clamp the aorta, put a cork on the cardioplegia line, put it in the side. Now we will open the left atrium and introduce the blade, and then retract the left atrium. This is the Barlow disease, very bizarre. Usually we are doing in the same manner, but here we put in some stitches randomly just to expose the wall. As we place the ring, now we're anticipating here on the A3, B3, maybe later on, prolapse irritation, and that is the reason why we're going to place the neocords on the anterior leaflets. In this case, we use the pre-measured neocords, and as we place the neocords, we will also use the core nut for securing the neocords. And then, as you can see here, next step is to place sutures on A2, as we can see here. And as we secure the valve, we will do the examination, how it looks like, and if you're happy, we will proceed with the further steps. So in this case, we use the 2 neocords, and this is how it looks like after the operation. So we don't have any mitral regurgitation. Everything looks nicely without any gradient. So this would be like nice plastic for the patient. And this is how it looks like after the operation. So we have around 2 centimeters scar on the right chest. So this is the same patient on 6 post-op day. And this is her testimony.
My name is Mariana Knežević. I was operated on cardiosurgery, Department of Clinical Center, University in Sarajevo, 6 days ago. The reason was severe mitral regurgitation. After the operation, I spent a night in the intensive care unit and a day on Department for Standard Care. I was in hospital in total less than 72 hours. I feel good and ultrasounds control, everything is okay.
Beside the repair, they're also doing the endoscopically HLR replacement using the ramp devices, as you can see here. And the technique of the placing the suture, metric sutures into the annulus with the RAM device. Also, here there are some methods of repair for the mitral valve repair using the Virtuoso device instead of with a long shaft, with a holder. Sometimes it is much easier to do it, like we can see here, and just wearing the stitches into the annulus and the ring. Those are the novel devices for left atrial closure, C1. This enhances the procedure and makes life for our surgeons much easier. And those are the cases with some kind of complications and how to deal with them. First one, if you are going through the axillary approach, sometimes it's very sending out is very distant. So in this case, we are going to use, as you can see here, proximal trocar, or where we use the endoscope to see the operation. Through this, we are going to deliver the cardioplegia. And as we finish the cardioplegia, as you can see here, we will put the cord on the cardioplegia line and use the endoscope to push it through the proximal port. And then we will continue with the operation. We will have nothing. And Mineral also we will place the somewhere in the right hemothorax. This is the case where we, during the procedure, and the only atrial lymph retractor broke, as we can see here, but we didn't do the version. We continue with the operation and finish it. My assistant, he was keeping the blade in the position, so we successfully finished that operation. Also, this is the case that we had the rupture of the left ventricle with the vent line. As we start to wean the patient from CPB, we find out that on the obtuse lateral wall of the left ventricle, we have a bleeding site, as we can see here on the monitor up there. So we didn't proceed to conversion. We just opened on the opposite side on the left thoracotomy laterally and find that this is the place of the bleeding site. So we will do it with the Teflons, tapes, and as we reconstructed the rupture, we close the pericardium. We transfer the patient from the CPP to the VA ECMO for the next 12 hours just to keep the heart unloaded. And then after that, we weaned from the ECMO and then extubated the patient in the next hours. So to work on increasing number of multicenter, what we should done for increasing the number of endoscopic cardiac, we should accept new technologies and devices, and also have to encourage the new generation of the surgeons and to design education for them to adopt this technique. This is my presentation. Actually, I'm now in the Sarajevo airport, and during the meeting, I think I'm going to be over Greenland, and if it would be possible for me to say hello in live, I would like to. So thank you once again for having me in this meeting, and until next time, thank you.
Thank you very much. Very interesting talk, even though our colleague is not here. It's nice to share complications too, because it shows that, this is a real life surgery. So Apostolos Rouvelakis, who's the director of the minimal invasive cardiac surgery department in the Athens Medical Center, yes, because the titles of the hostel change, not your title.
It's a different, yeah. Thank you for the invitation, and it's a pleasure to share ideas with colleagues from across the Europe, maybe across the whole of the globe. It was a very interesting presentation, what we saw, and I think the main point that we need to keep with regards to minimal invasive cardiac surgery, and especially with regards to minimal invasive mitral surgery, is that we're reaching a point where the minimal invasive mitral surgery is gaining ground because it's becoming a bit more standardized. We know the techniques of repair. We've standardized that. We prefer, for example, using cords instead of resections, and we like using rings. And then we start standardizing the way we put the patient on the bypass and how we protect the patient, the incisions we do in order to avoid stenotomy. And we have good results, which are, as the mini mitral trial showed, equally good with the stenotomy. So that's the main point, that it's gaining ground. But one of the important things that were mentioned at the talk was that as the incisions are getting smaller, we should be a bit more prepared. We should be having extensive CT scans and echocardiograms, and have as much information as possible we can for the patient, because we don't have access with our hands inside the wound. We don't have access with our hands inside the heart, so we can't really assess things as we are used to in our training. And I think the most important factor is be prepared as much as possible and standardize the technique in order to be able to attract more patients and attract more surgeons to embark into the minimal invasive surgery journey. Thank you.
Thank you very much, Apostolos. Okay, so this was very interesting, and I think would like our perfusionists to engage in the conversation too, because you have a key role in all this, and when it's not the anesthetist's fault, it's the perfusionist's fault, because it's never the surgeon's fault. So let's move on now to listen to a colleague who would like to talk about the benefits of HTK. Is it a recorded, or is he in minimal invasive cardiac surgery? He's live. He's a senior clinical perfusionist in Brighton, Sussex University, from the NHS Hospitals in England. So is he with us online? Dr. Vieira?
Yes, can you hear me? I'm gonna just share
Thank
my.
you very much. Hi, thanks for being with us.
My pleasure. Okay, my senior perfusionist here in the UK, the United Kingdom, in the Royal Sussex County Hospital, and I'm going to talk about our experience here using the custodial, and I'm going to give you a bit of the insight from a perfusionist with a few tips and comments that I ought to be useful for this arena. Can you see my screen well? The custodial is, we have been using custodial as a solution for myocardial protection, and just the key principles of action for any cardioplegic solution, we should have in mind in general lines two things. One is minimizing energy requirement of the organ for the duration of the ischemia, inactivating the cell, and secondly, optimizing the anaerobic energy production for the duration of the ischemia. So we can do this artificially buffering the organ. So specifically with the custodial, we have several kinds of cardioplegia for myocardial protection, and the custodial is in the category of intracellular crystalloid solution. Why they call intracellular? Because of the low electrolyte levels of sodium and calcium. So there are two mechanisms of the arrest of the heart using this cardioplegia. The first one is the sodium depletion in the extracellular space, so resulting in the hyperpolarization for the myocyte plasma membrane, so inducing the cardiac arrest in diastole. Also, the low extracellular calcium solution, the custodial solution, arrests the heart in diastole by inhibiting the excitation contraction coupling. So the custodial is a different solution, like we used all over the world, the St. Thomas cardioplegia, that is, we change, it plays in different mechanisms of arrest. We call the depolarizing arrest, extracellular solutions. So custodial also, we have the histidine that acts as a buffer in the scavenger, and you have also the tryptophan that stabilizes the cell membrane, and the ketoglutarate that supplies energy substrates. So that's the main components of the custodial cardioplegia. You have also mannitol that also works as a scavenger. So this custodial here in UK has been approved specifically for cardioplegia in myocardial in cardiac surgery operations in 2022. And here in our institution, our hospital, before we haven't simply bought the cardioplegia from the supplier and start using. This process has involved our perfusion department, has involved the anesthesia department, the surgeon, the lead cardiac surgeon, the pharmacy manager, and the medicines governance committee. So it wasn't simply just buying the solution and start using straight away. So we went through several processes in our hospital involving multidisciplinary team approvals and and establishing guidelines and protocols. So our experience here in Brighton, we started using these since May of 2007 in the minimally invasive mitral valve surgery program. And we know, and it has been proved that this solution is an effective and safe, as well convenient, because of the single dose method. So in minimally invasive mitral valve surgery, so the early stages of the learning curve is we have the cross clamp times, higher cross clamp times. So we wanted to change this standard approach of a high strength potassium plegia with the St. Thomas plegia that you have to re-administer every 20 minutes, 25 minutes or so. So you know, as a surgeon, it's releasing the atrial retraction in the minimally invasive cardiac surgery is very disruptive and time consuming. So you have to release the atrial retractor, otherwise the aortic would be distorted and the plegia wouldn't go to the left ventricle. So all these processes are time consuming. You could imagine this in a very small hole. So we started shifting now towards this cardioplegia, this type of myocardial protection. So we went for formal visits in various experienced centers here in the UK and abroad. In the beginning of the custodial, I'm talking about a bit of our learning curve. In the beginning of this, the usage of this strategy for myocardial protection, we had a patient group selection with no aortic valve regurgitation in normal coronaries. And I can talk about a bit more about why this kind of cohort of patients. We started not immediately in the minimally invasive cardiac surgery. We just using as a full sternotomy approach in elective patients. Very important adherence to of the institutional protocols, so that we established before, according to that slide that I mentioned before. And with that, we gain confidence and experience, and we start to advance these to complex cardiac surgeries, combined valve procedures, complex aortic, like frozen elephant trunks and redos and so on. In our practice, I'm gonna specifically as a clinical perfusionist here, we have some reference values. So the induction and the subsequent delivery time of those time of dysplegia is critical. So we have 2 liters of about 6 to 8 minutes. So it's a completely different kind of cardioplegia when the surgeon will expect a very rapid diastolic arrest using potassium, as we've been using. This cardioplegia is different. So time is the essence, because we're going to be displacing the blood from the coronaries, and the pressure is much lower in this cardioplegia. It's not a blood cardioplegia, it's just pure clear fluid crystalloid plegia. So the reason for that, we ensure that the homogeneous distribution and equilibration across the extracellular space in this tissue. And in addition to that, we're going to ensure the cooling of the myocardium. So this time should never be cut short. So the surgeon put a cross clamp and take it and relax 6 to 8 minutes and wait the patient to act. So the temperature of this solution is delivered around 3 to 6 degrees Celsius. The initial dose is 20 ml per kilo, and maximum of 2 liters. So normally you're gonna see values around 1,500 to 2 liters. This 3.5 liters is unusual. It's just in case we have some adversities like leaks and so on. But the dose of dysplasia is 20 ml per kilo, the initial dose. The subsequent dose is just half of the first dose, is 10 ml per kilo. So give a liter of dysplasia if you need to give replete the heart. Antegrade delivery. We have a few specificities with this cardioplegia. So we not measuring the aortic root pressure. You know, the aortic root pressure is something around 55, 60 millimeters of mercury. We're measuring here the line, the cardioplegia line pressure. So normally we will get around 150 millimeters of mercury. This is these are information, very specific information from the perfusionist view. So after the electrical arrest of the heart, so why do we give this initial burst, a fast burst? Because we want the aortic valve to close. So after the arrest of the heart will arrest normally between 300 ml to 700 ml of dysplasia. So we reduce the line, the flow, and consequently the pressure of the line to maintain something around 70 millimeters of mercury to the remainder of the dose until we complete the dose. So we're gonna time it properly to last up to 80 minutes. Maintenance of the dosage. The perfusionists will notify the surgeon. Here in our centers, we know that this kind of cardioplegia we can use for up to 3 hours with just one dose. Here established, and it has been safe and effective. After 90 minutes, we just let the surgeon know. So the surgeon can relax doing his loop repairs or in the mitral valve up to 90 minutes, and I'm not going to disturb the surgeon. So from this point, he can have in mind that you may give a subsequent dose or not. So we've been doing this, using this plegia around 120 minutes without redosing and working absolutely fine, effective with any other problems. So the subsequent dose should be given in this case if the electrical or mechanical activity is evident. So if you need a redose, we will redose this plegia. Some technicalities, some tips here, the custodial. So I've seen our noble colleague anesthetist in the beginning mentioning the importance of the TOE, the transesophageal echocardiogram. So that's it's paramount during this arena. Why? Because they're going to inspect the LV. So if you're giving this cardioplegia, and that therefore cohort is very important to this patient doesn't have any aortic incompetence. Otherwise, this plegia would distend the LV and you'll be defeating the object. So very important for the use of custodial in minimize competent LV. So during the induction of this cardioplegia, the anesthetist will be assessing the TOE and having a very close look in the LV to avoid or to pick in time any distension. Again, the clamp there's obvious information, but the clamp aortic cross clamp should be properly placed. If doing redos, the lemur should be clamped because this cardioplegia is very sensitive to washout. These cardioplegia line pressures are very, very low because, as I mentioned before, there is a very low viscosity, and the high pressures would cause myocardial edema. So the aortic root pressure is not measured. Bear in mind, you don't measure the aortic root pressure in the DLP cannula. You're measuring just the cardioplegia line pressures, and these would be essentially around 75 millimeters of mercury. Obviously, the cardioplegia line pressures, the rate of flow of the plegia is dependent in a series of specific parameters, like diameters of the cardioplegia, tubing, wall thickness, etc., etc., etc. So we very important. This is our standard, but we can discuss this further as a perfusionist point of view. Important to the duration time of the infusion of this plegia between 6 to 8 minutes. Again, aortic root, the TOE, we, as I mentioned before, we're going to observe the arrest of the heart around 300 to 700, after 300 or 700 mL of the infusion of this plegia, approximately 2 minutes, the heart will arrest, and from that point, the perfusion will time to last about 80 minutes. So a very quick maths, 250 mL per minute will take 80 minutes. It will give you normally two bags of liters of this cardioplegia. 20 mL per kilo is the recommended initial dosage. But if the patient, for example, weighs 80 kilos, so in theory, we would give 1,600 ml or 1.6 ml of cardioplegia, but it will extend for 2 liters for the 2 full bags of the cardioplegia. Obviously, if you're giving this cardioplegia, this is in the aortic root, and we will give the cardioplegia in aortic root based on aortic valve competence. In case of, as I've mentioned before, we extended for more complex cases. If you need to give this cardioplegia to the ostia, we also have to adjust the flows and pressures according to the small osteocannulas. But this would take, again, aiming for 8 to 10 minutes of delivery. In other exceptional circumstances, you may need to give this cardioplegia custodial through the retrogradely, through the coronary sinus, and again, note that if you're giving this cardioplegia through the coronary sinus, the right ventricle might be unprotected, so we may make sure we're going to give this antegrade right coronary ostia. We can observe a few flows around 250 mL per minute the coronary sinus. Importantly, this cardioplegia is 2 liters of crystalloids. You're going to note, in order to mitigate the hemodilution of the patients, you use a hemofiltration, and you add a bit of, with that, concomitantly, you use a liter of saline, 0.9%, and you add 8.4 50 mL of sodium bicarb, 84% into this bag, and you just drip very slowly. So hyponatremia is not a big issue for you. You run operation adults, and you're going to see normal sodium after the administration of the plegia around 112 or 120 millimole. But by the time we corrected the hemofiltration and add the sodium, these values come back to normal by the time we're ending the cardiopulmonary bypass. And again, so normal plegia scenarios, electromechanical activity and custodial is not different. So if custodial is very sensitive to washout, so if you have high non-collateral blood flow, exaggerated left bronchial venous return, it may wash out, so you may need to replegia again. Obviously, insufficient aortic cross clamp, venting of the LV, I would recommend using the vacuum assistance venous drainage, VAVD. Why? To keep the right side of the heart empty, avoiding washout of dysplasia. It's very common to observe some sort of ventricular activity around 20 to 30 minutes of elapsed cross-clamp time, but this will disappear without repleaging again. I would suggest, and we've been using frequently, and the topical slush, that ice in the heart, of observing, of course, the necessary care for phrenic injuries and so on. Obviously, the perfusion is not going to infuse blood into the coronaries in the circuit, because this would wash the plegia out. So to reverse this cardioplegia, we just reopen the aorta, and myocardial will be flaccid, and we can keep these lower pressures, and after 2 minutes we can increase the pressures. If you have persistent ventricular fibrillation, we have to look TOE for diagnosis. Again, TOE for intramyocardial coronary gas, graft kinking, spasm, and so on and so on. And in the case of the mitral valve surgery, look at the circumflex artery to see if any stitch has been caused any lesion or stenosis in these coronaries. Keep the heart vented, avoid distensions. We can give a few shocks, maximum to 6. Then I was talking to an anesthetist yesterday. He just really considered giving lidocaine before the cross-clamp release, lingocaine. We can give also amiodarone in the pump in case of persistence of ventricular fibrillation. If there was no heart mechanical activity or electrical activity during the case, this is a good indication that cardioplegia has been working fine. And finally, we can say that the cardioplegia we use as a single dose administration, and we extend the period of myocardial protection. Is effective, is safe, it's convenient for these complex procedures. It's less disruptive of the surgical flow, and we have increased surgical efficiency. I mean, the scope of this slides here is just not to talk about the length of stay, length of stay in the ICU, etc., etc. It's just to just give you very quick information, brief information about our experience here. Thank you very much.
Thank you very much. Congratulations. I think it's a great journey to follow on the cardioplegia substances. Give my greetings to Ishtak, who's a good friend from our training years. It's very interesting that most of the centers that use minimal invasive practice had to move from the blood cardioplegia. Have you had any experience with the Del Nido cardioplegia, which is what we found in our small journey to be a good compromise between the two?
Del Nido, we haven't used Del Nido yet, but I know I met him 2 or 3 times in New York in previous meetings, but we haven't used. I think it's a very interesting concept as well, Del Nido, because of the we use in Del Nido have blood is in a 1-to-4 ratio. I think there is a lot of space for Del Nido as well. I think custodial and Del Nido, they work together. And I think certainly there is a good use for Del Nido. I don't have any experience.
Thank you. Thank you very much. I think we'll hear the comments from Dr. Aristotelis Panos, who's a cardiac surgeon at the clinic of Athens Medical Center, and he's associated with the University Hospital Geneva, where he's been an associate professor and a lot of experience with minimal invasive.
Thank you for inviting me. Thank you, Dr. Mr. Vieira, for your extensive topic on this kind of cardioplegia. As I'm using cardioplegia custodial through more than 70 years now, I think is a good cardioplegia. And you had Dr. Pereas asked before for the comparison between Del Nido and Custodiol. I would add that Del Nido is also a good option, but for shorter procedures, and but does less hyponatremia, which is much less, hemodilution, which for some patients must be of good help. Now, concerning the protocol of giving Custodiol, we share the same protocol as you do, and we haven't had any particular problem. Usually at 90 minutes, if the procedure has to go longer, I do standard second dose with the same volumes. And finally, for the Custodiol, I can say that we have to monitor all the way through the whole way of CPB, the electrolytes, which is very important to have a very correct equilibrium of natrium and also the calcium. But we do not have to give early calcium before having a real hypocalcemia, because this acts and negate the effect of the cardioplegia and the myocyte. Otherwise, some studies, actually many studies, have compared head-to-head these cardioplegias between Del Nido and Custodiol, except for the duration. Otherwise, they are quite equivalent on the protection of the myocardium. And just for information, in Basel, years ago, in the early 2000s, they had developed a new cardioplegia, more for minimally CPB for the coronaries, which is the Cardioplexol, which is with 100 milliliters only dose, that gives quite a good protection for small procedures around 1 hour. And this contains potassium, magnesium, xylitol, and 5 milliliters of procaine. And is one shot very quickly, and is given by the surgeon directly in the aortic root. Thank you.
Thank you very much, sir. Any comments from our perfusionists? Because it would be nice to engage in a conversation for a few minutes. You've seen cardioplegias. I don't know, most hospitals are using most of them. Like we've been through more or less everything. Dimitris, would you like to make a comment? What is your perception on? Because this is a very important issue, and we all have. There were experiments from Backberg and Buxton in the past, but
yes,
now we don't have a lot of information.
Thank you. My name is Dimitris Poulis. I'm perfusionist at Onassis Cardiac Surgery. I work also with Dr. Pereas. Yes, we at the last 2 or 3 years, we have changed from the Custodiol to Del Nido with excellent results. Of course, Custodiol we used at the cardiac surgery for many, many years, so there is no any questions on any doubts about the value of Custodiol. But also the results of Del Nido is excellent. We don't have a hyponatremia, we don't have a big hemodilutions, and also we keep with the Del Nido, we keep the osmotic pressure in a very normal range. So we suggest the use of Del Nido instead of Custodiol. Thank you.
Thank you very much. Please.
Can I ask you, what do you believe is the safe cross-clamp time for Del Nido cardioplegia, and what time do you give an additional dose, and how much?
We have seen a very good cell protection on the myocardial for up of 90 minutes. Sometimes we have above 90 minutes, but for 100 and 110 minutes, we have excellent results. Okay, very good protections, and immediately after the cross clamp, we have immediately a cardiac rhythm without VF. Yes.
This is anecdotal, what Dimitris is saying. I've read it in papers too, because I was very, very much accustomed to the St. Thomas's in UK and then to HTK, which is slightly more expensive too. There's a lot of issues that make the decision.
I don't make any comments about the cost.
It's not the cost, but what I have seen frequently, even though we still use it in the transplants and the very long-lasting surgeries, the RV, this is anecdotal, and I welcome any comments. The right ventricle was always slightly more tired in the end of an HTK perfusion. That was my anecdotal impression with a few hundred of cases, not just a couple. And also what Dimitris is saying, when we open the cross-clamp with Del Nido, most of the time it takes less than a few seconds to get back into a rhythm, while with HTK, like Mr. Vieira mentioned, very frequently I do remember a few minutes of VF going back, starting back and forward. And I think he touched on all the important issues. With HTK, you have to be 100% sure there's no flushing of the coronaries. The cellular space as well as the coronaries have to be filled with this solution, because otherwise coronary blood flow can gradually decrease the protection of the heart. And if you add to that the possible RV dilatation that sometimes occurs during our minimal invasive cases, because the suction and the perfusion is not perfect, even though you guys are perfect. So these two make Del Nido sometimes, a good bailout option. That's how I felt. Anyway, thank you very much for your comments.
Okay, for Mr. Vieira, I would like to ask you if you use every time, in every case, hemofiltration with custodial, or maybe sometimes you put it on the cell saver, or maybe you suck it out.
Yes, the majority of the cases, it's just the surgeon preference. We use the hemofilter to mitigate the hemodilution, and there's no problem whatsoever. The levels of the hemoglobin are back to normal. But as you mentioned, yes, more in pediatric, we don't do pediatric surgeries here. But yes, that would be an interesting idea to open the RV and suck the custodial out to the cell saver. In adult, we can mitigate this with the pretty well using hemofilter. Yeah.
Okay, thank you.
Thanks.
Thank you.
Thank you. Professor Kofidis would like to make a comment.
Thank you very much. Very nice presentation. Now, if I'm also a Del Nido convert, I started with all kinds of cardioplegias, tried out custodial for the most part. 10 years ago, we switched to Del Nido. But the devil is in the detail. And I would just add to the very valid comments made that we personalize it for every patient. So minimal invasive bypass surgery, for example, is a routine in our program. And I feel that Del Nido doesn't work so well if you're dealing with severe ischemia. So we went back to use blood cardioplegia in ischemic cases. Now, if you run into trouble, of course, which I will refer to later, in minimal invasive mitral aortic valves, then there are escape routes. Again, there's no black and white. Del Nido is fine, but then you have different weapons in your armamentarium. Cool down further, do it on the beating heart, fibrillating heart, whatever. So there's no surgeon here with experience in minimal invasive who hasn't been in these situations before. So Del Nido, yes, in my opinion, but we're not religious about it, particularly in ischemic or suspicion of ischemia.
Thank you very much. Shall we? Yes.
Thank you very much for all these comments. From my point of view, I copied from Dr. Bakhtiari in Bonn, his protocol, just 1 liter of custodial for 60 minutes. So I prefer to do minimal mini sternotomy for AVR. So for AVR, I prefer to give just 1 liter of custodial. And if I don't want to give custodial and to give del nido. I think that it is the safe period for del nido is 60 minutes. If you don't want to have any problem, you have to give custodial for 60 minutes, and after that to give more del nido, and after that to give another dose of del nido for the next 60 minutes. Thank you.
Thank you very much, Christophorus. Okay, thank you, Mr. Vera. Thank you very much for your contribution. Hope to see you again soon. Bye-bye.
Pleasure. You're welcome.
So, for the sake of time again, we'd like to call to the podium Professor Kofidis, who is an expert in minimal invasive, as we just heard. He's a professor of surgery in Singapore, and he's the chief director of the International Heart Surgery Center of the first cardiac surgery clinic at Hygieia Hospital. Dr. Kofidis, thank you very much for being here.
Well, thank you very much for the privilege of the podium, and I would like to thank the Society for having me here again. It's always a pleasure to help with the lessons, which I hope will be turned to a bit more interactive experience now. It's supposed to be a lesson, right? And now my task today is to share or survey upon my own mistakes or my own experiences in minimal invasive cardiac surgery. And because it's a daunting task to talk about problems that can occur and how to stay out of them in the entire field of minimal invasive, let's talk with a staple of minimal invasive surgery, which is the mitral valve. So I'll try to show you different tips, tricks, and caveats, as well as some vignettes. These are my disclosures. And here are my disclaimers right up front. I've been in trouble quite a few times. Otherwise, you cannot gather experience if you don't run into trouble and troubleshoot. The tips and vignettes are confessions of precious own errors and painful experiences over the last maybe almost 20 years in minimal invasive heart surgery. Or I learned from mistakes of others. So I guess you will agree that the best way to stay out of trouble is to avoid getting into trouble. How to avoid getting into trouble in minimal invasive heart surgery? Well, the first part of my presentation is a bit philosophical. We have to assess ourselves and know where we stand, our experience, and our type of surgeon we are. In my view, there are three types of surgeons. There's the brainy surgeon. I had many of those colleagues like that in my experience, where they study the case, they read the notes, and they reread the notes, and they dream of the surgery the next morning when they go to sleep the night before, and these are the brainy surgeons. I've seen brainy surgeons do the proximal anastomosis twice and 3 times over, just to be safe that it's not going to bleed. Now, the other type of surgeon is the manual surgeon. Back in Singapore, as well as here, I see a lot of surgeons, and I appreciate them, and they're manual. They're painting when they're operating. Perfect distances, accuracy, no much repetitions, economical work. I call them the Picassos of the surgical theater. And then there is the chi surgeon, solar plexus surgeon, who is operating sensationally. He may run into a bit more trouble. Now, all of us, I believe, have elements of those 3 types of surgeons. Okay. So we have to understand what type of surgeon we are in order to stay out of trouble and respect our weakness. So we should work towards incentive alignment. If you're alone in your program, nobody's supporting you, your CEO is not supporting you, you are not getting the instruments you need, you're going to run into trouble. Your ambition alone will not carry you. We need to form a stable team, get mentored, and of course, persevere. It's okay to have some conversions in the beginning of your experience. It's okay to have failures, but then you have to persevere and experience. Mitral valve surgery is a bit, or minimal invasive heart surgery altogether, I would say, is a bit like piloting planes. That's my hobby. I like flying airplanes. And they taught us at school, divide attention. You always have the horizon, the instruments, and the communications. Isn't that like that with the perfusionists in the operation theater? If we don't communicate, we're going to run into trouble. And I'll show you examples of people not communicating. there are programs that say, okay, you have to go to ALS, so you have to go to Leipzig, you have to go to here and there or Singapore and stay there for 2 years and come back an expert minimal invasive heart surgeon. It doesn't work. How good a surgeon you are, or I am, or you are, depends on your genuine surgical protoplasm. So you must be a good surgeon before you go on to be a good minimal invasive surgeon. Or even if you start with minimal invasive, you have to do the right stuff. For example, drop our ego, get mentored, communicate, speak about our mistakes and the troubles we face in the operation theater. Good pre-op imaging, patient selection, preoperatively is very, very important to stay out of trouble. Good preoperative imaging. Avoid extreme situations in anatomy. Don't overpromise the patient and his family. Avoid certain anatomical situations such as severe aortic calcifications. Avoid pulmonary hypertension in the beginning of the experience above 75, not because you technically cannot do the surgery minimal invasively, but you may run into secondary troubles with the right heart and so on and so forth. Avoid certain types of patients in the beginning, like very short and obese women. Both anesthetists and cardiac surgeons may have problems with that, or very, very obese men, very low ejection fractions, former irradiation. We try in general to avoid going into extreme cases in the beginning. Don't always trust the imaging techniques. For example, echo, and I'll show you an example. Echo may show you that everything is perfect, but we had a case recently where my very experienced anesthetist, Dr. Spiridakis, told me there is something wrong with his left ventricle, like a diastolic dysfunction. It wasn't described before. So we must take all this into account, particularly in cases like that. You repair the mitral valve and the patient comes out and goes through the banana, so to speak, all right? The period of relative heart failure post-repair when you eliminate the leakage. So look at this, for example. I trusted the echo preoperatively. I studied the report. The anesthetist, who was an experienced anesthetist, that was back in Singapore, reported everything okay. I was supposed to do the tricuspid valve, so I didn't take any special precautions. I do the tricuspid valves minimal invasive on the beating heart without even snaring the upper and lower hollow veins, right? The superior and inferior vena cava. And then I open the right atrium and I see this. 3 centimeter ASD, how could they miss it? Then, of course, that changes your operation entirely. Okay, you have to take measures, come out of trouble in that point. Okay, eventually cool down a bit further, put the head down, apply CO2, stitch it up. Okay? Now, this is a good case, this is a bad case. Which is the bad case? Obviously, the right one is the bad case. So one would naively think at the beginning of the experience that, thin patient, perfect. Minimal invasive, thin patient, it should be okay. Nice case to start with. It's not always true. Marfans or Marfanoid patients like this, they have a very verticalized heart. And you see the lateral view, there is so little space between the spine and the chest bone and the sternum. So when you take this patient on fem-fem, the heart totally evacuates and drops over the spine to the left side, and you can't see any mitral valve. Even if you can lift the heart over, how? Your anesthetist, again, is of good help. He will blow the left lung, bring the heart back to the right side. But you still cannot see the mitral valve because the heart is verticalized. It's totally tilted. Now, if you just do a replacement, you may be lucky. But if you go in for a Barlow's in a case like that, you will suffer. Here is a 51-year-old Malay male who didn't want to get operated for many, many years. He waited. Then he ended up with this heart, with severe mitral valve regurgitation, pulmonary hypertension, heart failure, cahectic, 40 kilograms, the guy. And then, of course, he got endocarditis on top of it, healed on antibiotics, but came in with a massive mitral valve regurgitation as an emergency at 8 p.m. Doctor, I want to have a minimal invasive procedure, he says. So I said, I can do it. Well, I did it, but I suffered. Okay, I'll just share a few aspects of the video very quickly. Now, it's not easy. Look how far is the SVC and the IVC. The full length of the instrument has to go in, and I have a few centimeters of space. By the way, I don't use snares anymore. I use vessel loops. You put a pern or you put a clip leave it on its own weight on the vessel loop, and it will take care of the IVC and the SVC. And then you find a valve like this, Barlow superimposed with infection, totally destroyed valve. Of course, here you have to know where to stop. In a situation like this, if you don't want to get into trouble, you don't start leaflet augmentations and extensions and repairs and neocords. Just throw out this valve and get done with it. So, and this is what I decided to do. The patient did well, spent a few more days in the ICU because of his pulmonary hypertension. You saw the valve specimen here. I'm not going to spend a minute trying to repair this valve. Valve replacement, therefore. So some patients are tricky. Don't get into trouble by doing it open. If this patient would come again and to a not so very experienced surgeon in the middle of the night, you just do a sternotomy and get done with it. Preventing trouble means looking at the preoperative imaging very, very well. You don't look at the preoperative imaging. Thankfully, this was not my case, but you end up with healing problems and so on and so forth. Diabetic, obese Indian patient is crying out for trouble. So open both groins for cannulation, and this is the result. Here's another patient, 65-year-old female. Normal coronary arteries, comes for the mitral valve, if I'm not mistaken, flail mitral valve, normal on echo, promising, can be done minimal invasively. Is there any problem with the pre-op X-ray? Everything's normal. There are some opacities. There is a bit of unease on the left upper lobe, no? So we run a CT scan, and it turns out she has cavities, she has a florid tuberculosis. So I won't insist to do a surgery minimal invasively if there is an active tuberculosis, and this was, by the way, affecting both lungs, as proven later. So femoral cannulation, we can avoid a lot of trouble if we know our cannulas, we know our flows, we communicate well with the perfusionist, and I believe keep it simple, solid, and teachable in any case. There are various ways. There are many ways to skin a cat, Perrier says, but keep it simple. So femoral cannulation, if you want to do a open cannulation, basically, you just go in with a 5-0. I don't like too many stuff, too many pledgets. There is a way to do it. I'm not gonna, stick to that very, very long, but perhaps show you just this small video. Here, my assistant, who is also the actor in this video, is pushing the wire for the femoral vein cannulation in collaboration with the perfusionist. Pushing the wire. Is that okay? Is something wrong with that? So this is not the way to do it. This is the way to do it. As simple as that. This is where mistakes happen and you can run into trouble. And minimal invasive heart surgery is, again, as aviation. This is the right way to do it. You see where the screen is turned now? When we push the wire, as simple as that. One eye is on the screen and one eye is down on the femoral. Many people just push, 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 and they anticipate that the anesthetist will turn the screen to you and he will look at the same time. Many things like this. Very minimal things, but can play a significant role. Then, preparation and exposure. If you have a difficult case, ladies and gentlemen. I hear for years now, and maybe this is one of our weaknesses, as opposed to the very well-connected and interactive 10, 12 times bigger cardiology community around the world. We all have our own technique and sort of do it our way. And I see surgeons now fighting. Of course, minimal invasive is in vogue and everything. Oh, I use a retractor. Oh, you don't use a retractor. I use a camera. You don't use a camera. My incision is 5 centimeters. Yours is 6 centimeters. It's nonsense. Yes, there are some minor differences, but there are many other ways in the entire patient journey where you can produce a perfect result and give the patient a good experience, not about the length of the incision. So, again, I would recommend vessel loops. Makes things easier, very easy to apply, and it doesn't take too much space when you work through a small work port endoscopically, then the vessel loops take no space. Okay, you just put some clips on them, clip them maybe under your Alexis or somewhere else, and it pulls the SVC and the IVC closed if you want to close them, to snare them. Do you have a right ventricle or an IVC under high pressure? Ask the perfusionist to pass you a big Fogarty catheter or a Coda catheter. So pull back the femoral cannula a bit, particularly when you do ASDs and things like that, okay? And you want to go into the right atrium, but the right atrium is very pressurized. You have pulmonary hypertension, right heart failure. Put a Coda catheter from the other groin, push it forward, pull back the inferior caval vein cannula, inflate the Coda catheter, and you have standstill in your operation field. You don't have hemorrhage in your operation field. Now, troubleshooting when you have calcified aortas. How many redos we've tried to do? We don't get access to reclamp the aorta. The aorta is very calcified. So head down, temperature down, CO2 insufflation, root suction eventually, even in cases of AV regurgitation. So if you go 30 degrees, 28 degrees, you will see the heart will get bradycardic, and it doesn't really bother you. The mitral valve annulus doesn't move too much. Now, troubleshooting around the annulus. Difficult view. I personally use the HV retractor because it has a side arm that pushes away the atrial fold, and you can visualize the mitral valve very well. You still don't have a good view. David Adams, for example, and many of us too, put the annular stitches first, so you can bring the annulus to a plane level, so you can see it and assess it better. Apostole, which retractor do you use for left atrial? The brown one, which has a similar mechanism. It has a mechanism to push away the... Okay. Okay. Αριστοτέλη, μπορώ να ρωτήσω? Delacroix Chevalier. Okay. All right. So, preference. Every surgeon has his preference. I find the HV retractor very good because it helps me look at the mitral valve, I believe, in my hands very well. Annular stitches first. If you have a weak posterior annulus and you go in for a repair, instead of doing the one passage with one needle, you can do the sandwich stitch. Both needles, in the posterior annulus particularly, go in the atrium, come out close to the annulus, in the atrium, come out close to the annulus. Basically, you use both needles and you reinforce the posterior annulus like that. Left atrial appendage, in larger atria, very enlarged left atria, I think we have to be concerned because the circumflex doesn't follow a straight line around the annulus. It's meandering oftentimes, and we may injure it where we don't expect it. Difficult trigones, there are techniques. You can put a few retraction stitches on the posterior side, pull the fibrous trigone towards yourself, and then you can stitch it easier. Forward, backward, or reverse backward stitches in an endoscopic fashion. Dealing with the leaflets. Errors of judgment, it can be less forgiving. Try to keep it simple. Of course, with growing experience, you're going to go into more complex repairs. Commissural prolapses and clefts, Prolin, magic stitches. Tying down cords after the ring is in. I usually do it like that. I tie my cords only when the ring is in so I can do a final test. Some rings will invert your posterior leaflet and change the situation again. Papillary muscles, I think I ran into this trouble before, pulling too hard on the papillary muscle, so papillary muscle tears. Even testing the valve, I will show it maybe in the next slide, which can be in one of the next slides, that can be a severe complication. Testing your valve, we sometimes use a catheter to go behind the valve and inject saline. Now, I would recommend to the budding minimal invasive surgeon, don't go too deep and don't do it with too much force. I have one patient in Singapore, very difficult to repair, very frail lady. I tested more than 20 times. You get nervous, you waste time, you use force, perforated the ventricle. So I had to convert. So these things happen. So actually the catheter itself perforated the left ventricle. So we just stay behind the leaflets and that's enough. Good exposure of the papillary muscles with this device, very, very important. How to avoid wasting time, for example, if you have access to Cornut, Procedure is difficult, is long. We use it in every single case. Use corno to expedite the procedure. Trouble the airing. Many people, because most of us transited from open sternotomy to minimal invasive. What do we do instinctively when we want to de-air in the end? Shake the patient, shake the heart. Wrong. If we've been insufflating CO2 for 2 hours, we produce the champagne effect or Coca-Cola effect. That is the phenomenon of microcavitation. More gas will go out of solution, produce bubbles, and cause air embolism. So echo, if it's okay, a few bubbles here and there, it's okay, leave it. Remove the clamp, head down, the usual tricks to the air. No Coca-Cola effect. Post-repair, my main point here is that if we don't like the repair, you see, I can fool my assistant, but I cannot fool my own conscience. So if I don't like the repair, I better go back on pump and fix it right there and then. Study the mechanism of the residual leak and go back and repair it. SAM, only one word on SAM. SAM is not a morphological diagnosis in terms of, the leaflet is hitting the septal wall. It's a functional diagnosis. So this is very important to remember. I had some junior anesthetists back in Singapore, I don't have this problem here, who called me back in the OT, hey, the leaflet is touching the septum, so what? Patient is off pump already, is doing great. So there are solutions for that, and you know it. So come out of trouble, put in a bigger ring, or use volume first, avoid too many inotropes. The most important slide is this one here. Bleeding. Bleeding from where? There's all kinds of bleedings in minimal invasive, and all minimal invasive surgeons here know that bleeding in minimal invasive doesn't forgive as easy as a median sternotomy. Is it bleeding from the superior vena cava? Usually easy to fix. Bleeding from the right atrial appendage, also okay to fix, except if the pressure is the right atrium is very pressurized. Cardioplegia side, also easy to fix. Usually the aorta is easy to fix endoscopically. Pulmonary artery, sometimes manageable. Left atrial appendage, start praying. You may be able to reach it. If you cannot, don't fool around. Patient is usually, you are coming off. Usually you see it late. I had once a resident I was tying down, he was holding the stitch, and we didn't have cornod yet. So I was tying down, he was holding the stitch. He didn't hold it well. I slipped with a knot pusher. I didn't see anything, everything normal. And at the end, I realized after we came off that the left atrial appendage was perforated. So immediate conversion. Left atriotomy, likely manageable. IVC, if it's posterior, you are in trouble. It's more difficult. And again, bright blood pooling behind the heart and you don't see the origin, convert, don't think about it. I told you about the perforation before. Wall motion abnormalities, we think of the circumflex. We give it 10 minutes, eventually we good the airing, and there are a couple of tricks to come out of trouble. Move the patient so your cardioplegia line becomes a de-airing line. Head down, fill up, good perfusion, maybe a 70-75 pressure mean for 5 minutes to kick out the air. But if all this doesn't work, always the surgeon has to think of the circumflex. Now, of course, again, philosophical, institutional support, build up a good team, work with the same people in the beginning is very, very important. And patient consent is very important. We try not to tell stories to our patients, okay? They need to know about conversion. They need to know about complications that can happen so you don't get into medical legal trouble. Education is important. Best teacher nowadays is Professor YouTube. I won't miss the opportunity to tell you, get our book on minimal invasive heart surgery because it's made out of experience and pain over many, many years. We're going into the second edition now. You can scan the QR codes and see how the procedure is done. So back in Singapore, we have formed a simulation center. Important, if you want to stay out of trouble, is train, even simulate. I'm in a very happy position to share with you that we are soon inaugurating the same as we had built in Singapore, a unique prototype heart surgery simulation center here in Athens in the premises of Aegean Hospital. We're going to be opening soon and open it up for training. And we brought all best equipment in the world, digital and manual, for the training of young surgeons and even older surgeons who want to go into minimal invasive. Conclusions. MIS is a lot about tips and tricks to avoid trouble or get out of trouble.
Good planning and patient selection is a key to success. New technology definitely facilitates solutions. Preoperative imaging is very important. Teamwork and communication is very, very crucial. And I would recommend, from my humble experience, don't push, go slow, talk to your other surgeons. Don't put your ego first. That's the biggest problem in causing trouble. So this is a mantra, doesn't reflect myself, of course, but I'm saying that's what they say. Good surgeon knows how to operate or use a certain technique. For example, minimal invasive versus open. The very good surgeon knows when to operate or when to operate in a certain technique. But the excellent surgeon knows when not to operate and use a certain technique. Thank you very much for your attention.
Thank you very much. Congratulations. This was a very enlightening talk, and you touched on many issues with a lot of frankness, which is really what we need, I think, if we want to advance on this field in a constructive way. So any comments from the audience? Thank you very much, Professor.
And now we will continue from a perfusionist point of view. We will invite Themistokleos Vasilis, a perfusionist from Thessaloniki, who has a great experience also from Germany. And we are really keen on listening to you. Vasilis.
Hello all. Hello to the audience and to the auditorium. Thank you very much for the invitation. So I will speak about the extracorporeal circulation in totally endoscopic cardiac surgery procedures. Some historical data first. The idea came in the early 90s, and the first attempt made in Stanford in 1995, and they called that as port access. And we see now they use the femoral arteries for connection to the cardiopulmonary bypass and to give also the cardioplegia. And the aortic clamp was an endoaortic balloon. So in 3 different cities, 3 different surgeons persist with this idea, with their methods, and after some years, adapted many surgeons, one of those 3 approaches, and leading on this paper in 2010. And coming today, another team, another group of surgeons introduce us this statement for those who want to start an endoscopic cardiac surgery program. So our devices in our center is from Storz, the 4K monitor and the recording system, 4K camera, and the robotic arm from Storz. Our cardiac surgery spectrum includes almost the whole spectrum of cardiac surgery. Most of the times the incision is a perioalveolar incision. Our heart-lung machine is from Spectrum, and includes the monitoring system, which is crucial nowadays. Includes an 8-inch pump, 2 4-inch pump, and 3 6-inch pump. 4-inch pumps for suction and delivery with the cardioplegia. Also includes the ventilator system, which has also a vacuum assist device, which is important in the endoscopic cases. So our occlusion protocol method, actually, which we are performed in our center, is based on a study from Tamari and called hemodynamic occlusion or non-occlusive method. This method can reduce the hemolysis, which is produced from the pump in a degree less or in the same degree as a centrifugal pump. The initiation method we are using is that we are going on full bypass and cover the 100% of the cardiac index on at least 90 seconds. This protocol is based in a study from Germany, which the results showed that the oxygenation of both hemispheres are better when we are going slowly on full flow than fast, like 30 seconds, for example. These results confirmed also from us on our single center study last year. Of course, we are using a goal-directed perfusion. This protocol is well described in many studies and included also in the last guidelines of cardiovascular perfusion. And it's very important to monitoring the whole parameters like DO2, VCO2, VO2, but the big difference between the endoscopic cases and the full sternotomy cases, it's because we are fluiding carbon dioxide in the field. The carbon dioxide goes into the reservoir, so the carbon dioxide make all the parameters faulty, but one parameter stays reliable, and this is the delivery. So delivery oxygen, the DO2 is always a parameter that you can check and you can trust. So for the cannulation, we use the femoral artery and the axillary artery. And for the venous cannulation, we use the femoral vein and the internal jugular vein. The method can be surgical incision or percutaneous method. And always we confirm the method with the transesophageal echocardiography. The cannulas we are using is either the Medtronic EOPA 18 or 16 French or the Edwards Flex cannula. And for the venous cannulation, we use 21 French or 25 French multi-stage cannula. Because of the small size of the cannula, we need to use a negative pressure, so the venous assist device is important in every case. Our cardioplegia is the custodial cardioplegia. We give 20 milliliter per kilogram as initial dose, either in the aortic root or selective in the ostias. This can be in 6 to 8 minutes for a nice equilibrium. And after that, we wash the whole volume with the use of the hemofilter. So now I have prepared some videos, some incidents in order to realize how important it is to react fast and to stay focused on the screen the whole time. So here we have a cannula dislocation, and we have the negative pressure in a high amount, so the right atrium is not empty enough. The negative pressure is going higher in order to empty the right atrium, and we see that the cannula now is in a good position, and we realize that the negative pressure was so high, and now we need to normalize the negative pressure in order to avoid this banking of the superior vena cava. Here we have an obese patient. It's difficult to do endoscopic case to obese patient. You don't have a full empty right atrium. So what to do, you can reduce the temperature And if you have a good hemoglobin, you can reduce flow, easily go down to 1.8 cardiac index if you have 32 degrees of Celsius, and always check the delivery of the oxygenation. Here we repair the mitral valve. We are looking that it's not empty enough in the field. There is a blood. That is because of the suction in the pulmonary vent is collapsed into the pulmonary artery, and now is sucked very nice. The surgeon needs only to suck the field to see better. Here, a splatter on the camera can be a big mess. You cannot see nothing at all. What you can do, maybe increase the pulmonary suction, maybe lower the flow a little bit. You see nothing at all until the surgeon cleans the camera. This is a big mess, actually. Now we see that the right atrium was full, the pulmonary vein wasn't sucked enough, and now everything it's okay. So it's very crucial to see the whole time the camera and the monitor. In this case, we give cardioplegia. A big amount of volume goes inside the heart. I have increased the negative pressure. Maybe I have reduced also a bit the flow in order the right atrium and the whole heart stays empty. And then the cardioplegia will stop, and we will suck the root vent. You will see in a minute. Now we suck on the vent. Because of the high negative pressure, now we'll start the superior vena cava to pumping, because now the volume inside the heart is empty. So to avoid this, we need again to normalize our pump in the normal flow and to decrease the negative pressure. Here is a tricuspid valve. You see there is a nice red blood pool. We cannot suck air, and the surgeon can see very nice what he has to do. But it's not always like this. It's not always that you can find balance in these cases. You see that in this case, it's difficult, but don't panic. There is a solution. There is a solution for everything. So you need to communicate with the surgeon to put suction in the field and use this suction as an assistant to find the balance between not to suck air and the surgeon to see. Now he can work nicely and could be also happy. So we spoke about the carbon dioxide in the field. It's crucial to give to fluid carbon dioxide because of to reduce the intracardial air. But in cases that the right atrium is open, you need to go very high in the ventilator system to eliminate the carbon dioxide from the oxygenator. Thank you very much.
Thank you very much, and congratulations for this analysis. I do think that getting good communication and expertise from the perfusionist is very helpful, particularly when you're using the blood-air interface as you do on your right side surgery, which you showed very elegantly. Would Dimitris like to make a comment, please?
Vasilis, thank you for excellent presentation. You are highlighted with an excellent way some differences between the traditional opening surgery and the minimal invasive. Also, you have mentioned how important is the management of the arterial and vein, because especially at the minimal invasive, you need to have a big experience like a perfusionist, many miles on the machine, a heart-like machine, and you have to face some very important differences, especially when you have to have approach of femoral arterial and vein, and you have to manage very accurately and not only accurately, but you have to manage the negative pressure if your target is to help the surgeons and to create a special clear field, surgical field, and the negative pressure is also a weapon, and sometimes also with a bad or good results. And also another very important point that you have make a mention is the communication between the perfusionist and the surgical team. If you want to have the best results, as mentioned before Professor Kofidis, you must have excellent communication between perfusionist, the surgical, and the surgeon. In a recent article, I have read that the perfusionist is the secret gem in the operation room. Could have also the role of the communication between surgeons, anesthesiologists, and nurses. Thank you, Vasilis.
Thank you very much for the comment.
Thank you very much, Dimitrios. There's a question from the audience about the size of the venous line. I think, of course, your views are very valid, but it's not just a matter of size, but the kind of venous return you use. If you use jugular, do you want to comment on that, Dimitrios?
You have also to compare what you want, but what the patients and the anatomy of the patients give you the opportunity to use. It's not so simple, and I think it's not a rule. This is a point of that we said you must have a lot of miles on machine, a big experience, and only on that case you can help the surgeons. The size is not only a matter of bibliography. You have to adjust to the patient.
Thank you very much. Yes, please. Some more comments from our colleague.
I want to thank also Vasilis for his excellent presentation. And from my point of view and my experience right now on minimal invasive, I have to say that we all have to work as a team. The experience of the surgeon, of course, is a key play for the whole team, but also the machines that we are using, the spectrum give us the opportunity to go and help the surgeon in a different way, because we can use all the other values like DO2, VCO2, and to see the perfusion in that way. In our hospital, we use the Livanova, the Stockert S5, and now we are using also the Big Apta and the card, so we are using Gold Direct Perfusion. And that is the introduction for our next webinar and the last for this year, which is going to be focused on Gold Direct Perfusion. Thank you, Vasilis. Thank you,
Thank
Dimitris.
you very much. Thank you.
Thank you very much, too. I think just to make a comment, too, on all this, what we really need around the world, but in Greece a bit more, is a lot of real data with very honest information, without judging, without trying to pinpoint one to the other, so that we can improve our knowledge. You see, there's so many techniques and so many instruments and weapons in our hands as we're in the army, but we really need to learn which one is useful in each situation. And of course, insights and our general anecdotal beliefs are important, but I'm sure we can create data if what Professor Kofidi said, we forget about egoism in all this and we just try to create enough data so that we can advance. It's very impressive how much better we become as we try and we improve. So I think this is a key message that comes from the communication, as Dimitri says, to, I do like to shout sometimes, don't I? So yes, you have a really central role in getting the good communication, and it's very important to have visual contact too. This was very nice, as you showed. We spent about a year with our senior anesthetist, not Dr. Falara, trying to convince them that the monitor should not be under the anesthetic sheet, as you said, it should be above, so that we can both share the picture. So thank you very much. This was, yes, please, comment?
For Vasilis, maybe have you ever faced, are you using
I'm not sure if he can hear you.
Hello, this is Angelina Chorba from Henry Dinan Hospital. Hi, Vasilis, how are you? I have a question. Do you apply any vacuum, and if you ever had any trouble using vacuum?
So,
for
vacuum,
venous return.
yes, so in every case, in 90%, we use the vacuum assist device. I think it's almost 100%. We cannot perform endoscopic case without the vacuum because the right atrium remains full of blood because of the size of the venous cannula. They are small. We apply sometimes minus 70 millimeter of Hg negative pressure. It's a bit high, but you cannot work without it. And as my experience also in Germany, these values of negative pressure is high. Or for any problems, no, I didn't see problems. Sometimes we see hemolysis, maybe because of the time of the cardiopulmonary bypass, but I didn't do any study about the hemolysis that can react against the negative pressure.
Okay. My experience, it was actually many years ago, applying vacuum on my venous side, venous cannula, and the cannula was bented, kinked on the table, and then fortunately it was right before going on bypass, and the whole system was emptied, sucked, So that was a little bit, this experience was a little bit weird. And fortunately, it was right before going on bypass, so I had time to recirculate and remove all the air. So I was wondering if you ever had to experience such a case.
So in the bibliography, you can find incidents like if you apply a negative pressure before the bypass, then you have a closed system, and the oxygenator can be sucked into the reservoir. So you have an opposite way of the water. But this happens if you have a closed system, and sometimes the perfusionist apply negative pressure before going on bypass. So this is not a good idea. A good idea is to go slightly into the bypass, maybe 20%, and then apply negative pressure to avoid this incident.
So you go first on bypass for a few minutes, and then you apply the negative pressure.
I'm going on bypass maybe 1 liter, and
minutes
then
later
apply
you apply
pressure.
the vacuum.
Yes.
Okay. All right. Thank you.
Thank you.
I had just a comment on the pressure you go, or the negative pressure of 75. Don't hesitate to insert another cannula, a jugular cannula. 14, for example, French in larger patients can avoid this and still work with 35, 40 max of negative pressure. Thank you.
Yes, indeed. In some centers, they are cannulate also the jugular vein, and they have a jugular vein and femoral vein cannulated. Unfortunately, in our center, we don't do that, except in a few cases like AVD or ASD.
So as we conclude today's sessions, I would like to emphasize one key takeaway. Success in thoracoscopic cardiac surgery is never the work of a single pair of hands. It's the result of coordination between a surgeon, anesthesiologist, perfusionists, and not forget nursing staff and the entire operating room staff. So thank you all for participating in our session. Thanks a lot to the speakers for their excellent presentations and valuable insights. We look forward to seeing you at our next session in a month from now, 28th of May.
Okay, on the 28th of May, the last Wednesday of May, we are waiting for you to watch our session. It's going to be about goal direct perfusion, as Victoria said. Thank you and have a good night.